Ectopic pregnancy is defined as pregnancy implanted outside the uterine cavity. It affects about 11 per thousand pregnancies, and slightly much higher at about 2 to 3% in women attending early pregnancy assessment units. Common symptoms of ectopic pregnancy include pain, bleeding, amenorrhea. And the common signs include any form of tenderness, abdominal tenderness, pelvic tenderness, or cervical motion tenderness. Ultrasound features of ectopic pregnancy may be indicative, high probability, or possible features. There is only one indicative feature of ectopic pregnancy according to NICE guideline. It is the presence of adnexal mass, which moves separately from the ovary and contains yolk sac or fetal ball. This fetal ball with or without fetal heartbeats. This feature is indicative of ectopic pregnancy. High probability feature is the same as indicative feature, but without yolk sac or fetal ball. I mean, it is the presence of adnexal mass, which moves separately from the ovary and contains empty gestational sac. This feature is called tubal ring or Bagel sign. Another high probability feature is the presence of heterogeneous mass, which moves separately from the ovary. Possible features of ectopic pregnancy are related to the uterus. It includes empty uterus or the presence of fluid inside the uterine cavity known as pseudosac. Sometimes ultrasound cannot define intrauterine or extrauterine pregnancy, while pregnancy test is positive. This is known as pregnancy of unknown location. NICE guideline advise to measure HCG twice, now and after 48 hours. If the change between two samples of HCG decline more than 50%, this means pregnancy is unlikely to continue, and advise the woman to repeat UBT after 14 days. After 14 days, if the pregnancy test becomes negative, no further action is required. While if pregnancy test remained positive, refer the woman for early pregnancy assessment unit within 24 hours. After 48 hours, if HCG increased more than 63%, pregnancy is likely to be intrauterine pregnancy, and advise to repeat transvaginal ultrasound between 7 and 14 days after 1 week or 2 weeks. It can be repeated earlier, for example after 4 days, if the HCG is more than 1500. During repeat transvaginal ultrasound, if intrauterine pregnancy confirmed, send the woman for routine antenatal care. But if intrauterine pregnancy is not confirmed, review the patient by a senior gynecologist. So, what happens if the HCG change between decrease 50% and increase 63%? If this happens, refer the woman for early pregnancy assessment unit within 24 hours, according to NICE guideline. Now regarding the treatment of ectopic pregnancy. Selection criteria for treatment. As you know, treatment may be medical, surgical, or expectant. The selection criteria or the choice of treatment will depend on the selection criteria. For example, if there is no significant pain and the patient is hemodynamically stable and she accepts follow-up, gestational sac less than 35 mm with no fetal heartbeats, and HCG less than 1500. Offer medical treatment as first line, If the same criteria are present but HCG between 1500 and 5000, then offer a woman a choice between surgical or medical management. If same criteria but HCG less than 1000, offer expectant management. If same criteria but HCG between 1000 and 1500, then consider expectant management. If all the previous criteria is not present, I mean the patient has significant pain or hemodynamically unstable, she does not accept follow-up, gestational sac more than 35 mm, or fetal heart rate is positive, or HCG more than 5000, then choose surgical treatment as first line. Now what are the components of medical treatment? Medical treatment include methotrexate single injection. In the first day, day 1, take a blood sample to measure full blood count, liver function, renal function, blood group, and the baseline HCG. And inject methotrexate 50 mg per square meter body surface area intramuscular. On day 4, measure HCG. So this was day 1, 2, 3, 4. On day 4, I will measure HCG 5, 6, 7, and I will repeat measurement on day 7. And I will compare the result between day 4 and day 7. If there is a decrease more than 15%, then repeat HCG weekly until it becomes less than 20. However, if HCG decrease but less than 15%, re-evaluate the patient. And if she is still candidate for methotrexate therapy, I mean the same choice criteria, still HCG less than 1500, gestational sac less than 35 mm, with no fetal bone, with no fetal heartbeats, then the patient is candidate for another injection of methotrexate. What are the predictors of success of medical treatment? Initial HCG is a predictor. If it was less than 1000, the success rate is 98%. HCG more than 5000, the success rate is 38%. Ultrasound feature is another predictor. When you visualize yolk sac, fetal ball, or positive fetal heartbeats, these are significant predictors of failure. The change of beta HCG before methotrexate injection is another predictor. I mean, if there is a small increase in HCG, up to 20% in 48 hours, you suspect a higher success rate. What about the change of HCG between day 1 and day 4? Between day 1 and day 4, if HCG decrease, you expect between 90 and 100% success rate. But if HCG increase between day 1 and day 4, you expect a success rate between 40 and 60%. Now regarding surgical management of ectopic pregnancy. It may be by laparoscopy or laparotomy. Generally, if the patient is stable, laparoscopy is preferred, while if the patient is unstable, laparotomy is preferred. During surgery, we will perform either salpingectomy or salpingotomy. If the contralateral tube is healthy, perform salpingectomy and repeat UPT after 3 weeks, because there is still a risk of persistent trophoblast, which is about 4%. If the contralateral tube is unhealthy, then salpingotomy is preferred. However, with salpingotomy, there is a risk of persistent trophoblast about 11%. For this reason, we measure HCG 7 days after the operation, and we expect a 20% risk that a further treatment will be required, either in the form of methotrexate or repeat surgery. The last option of treatment is expectant management. In expectant management, we'll do nothing, just we will observe the patient and monitor HCG between day 2, 4, and 7. You remember, methotrexate we inject on day 1 and measure day 4 and day 7. Here we add another day, day 2. And again we will monitor the change each time. If it decreases more than 15%, this means we are going in the correct way, repeat weekly until it becomes less than 20. But if the decrease less than 15%, medical treatment is required in the form of methotrexate. Generally, the success rate of expectant management between 57 and 100%. Thank you.